we are going to be talking about models and frameworks, and then hopefully we'll have another session next semester where we'll get into more of methods and designs. I'm going to have Andrea just kind of monitor the chat. Andrea, if there's, where did it go? Hold on. If there's questions that come up during the talk, and then we'll definitely have plenty of time for questions at the end. All right, so I will get started. I will try to get started. There we go. Okay, so today we will be talking about implementation science definition and terms. We'll get into some models and frameworks. We'll talk about digital health adaptations, and then I'll provide some case examples. And I'd like to especially thank Dr. Badwani and Dr. Chapman, who lead the CTSA Dissemination Implementation Science Core. They have a website through the CTSA that you can Google and look up and have office hours and other resources. So I encourage you to take advantage of that. Also, the Implementation Science Coordination Initiative at Northwestern University has been very influential in the preparation of some of these materials, as well as Dr. Saloom from University of Florida, who runs a parallel disc, a CTSA disc over there. So to get into implementation science definitions and terms, I wanted to first just talk a little bit about the spectrum of translational science. And so the original NCATS, National Center for Advancing Translational Science, shows this continuum of translational science. And you can see it's not meant to be linear, but there is a process of basic research in the biomedical and behavioral and social sciences. Preclinical research is really where intervention development lives, but also new drugs and devices. Clinical research is where we have clinical trials, and then we get into clinical implementation, which is where implementation science lives, and effectiveness research is sort of in between those and can be done in hybrid designs, with the whole idea leading to improving public health. And in the original dissemination, developing new approaches, demonstrating their usefulness, wrap around all the stages of translation. However, there has been some newer models that talk about while we might be testing implementation over here in the later phases, that intervention, dissemination, and implementation is something that you should be thinking about across the translational spectrum. Some examples include frameworks for designing for dissemination. For example, the pilot projects that the CTSA has been sponsoring will have an evaluation for feasibility. So those are just some things to think about, that it's not just at the very end of your trajectory of intervention, development, and testing. Another way you can look at that is looking at the stages of research and the implementation pathway. So I'm just showing you this in a couple of different ways based on your discipline. You may have seen it in different ways, but you can see here where you've got lower real world relevance in the earliest stages. And so pre-intervention is like, is there even a relationship in your your target mechanisms and what you're trying to change? Then you get into, here is where your feasibility studies and live. Like, is this feasible? Is this acceptable? Does it even show any signal or proof of concept of an effect? Then efficacy, then effectiveness. So could it work? Is efficacy studies? Does it work? Is effectiveness studies? And then what makes the program work in practice settings? The official definition, and you can see this in a couple of different permutations, implementation science is the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine healthcare and public health settings. So, scientific study of methods to promote. So what this means is implementation science tests strategies to promote the uptake of evidence-based practices. So in implementation science, you are not testing the practice itself. That should have already shown efficacy, but you are testing the strategies by which you are going to promote this uptake and sustainability. And also, there is some early phases of implementation science that you can do where you actually do a a study to understand the determinants and develop those strategies, although these methods have not been as well specified, and Dr. Badwani and I are working on a paper in this domain. So another non-working definition to think about it, which I came from the Northwestern group, the intervention or the practice or the innovation or the device is the thing, or the medication, like HIV prevention medication. That's the thing. Effectiveness research looks at whether the thing works in real-world settings. Implementation strategies are what we try to do to help people and places do the thing. And the main implementations outcomes are how much and how well people and places do the thing. So this is just, I find this to be very, very helpful for trainees to understand the difference between intervention science and implementation science. So another way to think about it is the scientific questions. So for efficacy and effectiveness research, you are doing some things to support adoption and delivery with fidelity. You have to be able to show that your intervention is being delivered as intended, but you're evaluating health outcomes. So just because you look at fidelity doesn't mean you're doing implementation science. You should be figuring out your fidelity by, when you're developing your intervention. But the key questions here are, does the thing work in controlled settings, efficacy, and real world settings, effectiveness? Other questions that come up heavily here, what are the mechanisms of effect? When and under what conditions does the thing work best? Those are your mediators and moderators. For implementation, however, you are looking at a system to support adoption and delivery with fidelity. So you're evaluating quality, quantity, speed of delivery, whoops, I don't know what happened there. There we go. Those kinds of things are the key questions. Does implementation strategy A work better than B in terms of fidelity, quantity, quality, speed of delivery? Under what conditions does implementation happen best? What are the characteristics of partnerships that are sustained over time to ensure sustainability of the implementation of this intervention? So I would encourage you to think about these scientific questions when you decide if your grant is going to be implementation science. You don't have to do every grant as implementation science, but don't say you're doing implementation science if these are not the key questions. You're better off sticking with your efficacy and effectiveness trials, and you can have a secondary aim to start to understand the context of implementation. But the scientific question piece is really key. Okay, Andrew, just stop me if any questions come up. So now let's get into what are the models and frameworks that can help you guide your scientific questions, your study, and your methods and designs. And I encourage you to move away from the language of how we implement the study or how we implement the intervention. I see a lot of reviewers getting upset with people talking about this is how we're going to implement the clinical trial. Now that we have a whole science of implementation study, don't use that word. Use execute the clinical trial, enact the clinical trial, complete the clinical trial. You only really use the word implementation if you're testing strategies to actually implement an evidence-based practice. All right. So thinking about models and methods, there's a lot of things that you need to think about when you're developing your research design for implementation. First, what is the thing? What is the evidence-based practice or innovation that you're choosing? And making sure there is sufficient evidence. Has it had enough testing to do a full implementation trial, or do you need to consider a hybrid trial? And we'll talk more about that next time. You want to think about what is the implementation gap in the community, in the setting, and what is the stage of implementation readiness in the community? So, for example, there might be a strong implementation gap on doing culturally appropriate care in mental health in Florida, but the stage of readiness in Florida might be quite low to develop culturally sensitive and potentially inclusive strategies. So thinking about the gap and the stage of readiness, but maybe they're ready to implement tailored interventions. So that's something to think about as you're figuring out how you're going to implement the thing. There's the implementation process, which is sort of how are your strategies for implementation going to roll out? Are you doing training first and then coaching? Do you need to have preliminary sessions to increase readiness? What is the process of your implementation strategies? We have strategies and mechanisms over here. So these are the strategies that you pick and the mechanisms by which you think they will be effective. I can tell you now that mechanisms are often ignored, and we'll talk about that a little later. But so if I have my strategy is training, then my mechanism should be something that I am fixing with training, which would be lack of knowledge, lack of skills. And then implementation outcomes, there's frameworks for that, but what are the outcomes that you're going to assess? And then usually, even early on, you can start thinking about your contextual determinants. So if you're not doing implementation study, but everyone says you need to have some implementation because that's what NIH is looking for, you can have a exploratory aim of trying to begin to understand contextual determinants of implementation. So I have a clinical trial, but I want to start talking to key partners who might roll this out in the future to think about what are the barriers and facilitators by which implementation might be successful down the road. So those are all the different things to think about, and there are frameworks for all of them. What do you do though when you have so many frameworks? Your mentor says, oh, you shouldn't have more than one or two in your grant. And now, there are different frameworks for different things. Well, in the Northwestern group, they've been very much supporting a logic model approach. And in fact, in HIV implementation science, often they require a logic model in some of the applications. And these are ways that you can pull in your frameworks without necessarily having to like talk about all these different frameworks. So here are your contextual determinants that I mentioned before. These are the things that are barriers and facilitators to successful implementation. Here are your strategies that you're choosing to test to promote the evidence-based practice. Here are the mechanisms that you think the implementation strategies are targeting. Here are the outcomes. And then a lot of people, this you could potentially skip, but if you're doing a hybrid trial, what's the intervention? What is the thing? And what were the mechanisms of the thing? And if you're doing a hybrid trial, then you might also have outcomes related to effectiveness. So in if you think of one of my trials where we were implementing motivational interviewing to improve adherence in medical science, we've done a lot of work to show that that motivational interviewing improves adherence, and we think the mechanisms are through self-efficacy, motivation, and planning, like implementation intentions and planning. And the outcomes would be the viral suppression or the intermediary outcome of adherence to medications. So that's here. And if you have an effectiveness trial, you might still be specifying that. But what we really needed to specify were like, here are all the things that get in the way of implementing motivational interviewing: insufficient competency, insufficient time, insufficient leadership to support training and rollout. Framed positively, leadership that is supportive of these evidence-based practices, sees the need for psychosocial interventions to adjunct biomedical treatment. The strategies might be leadership strategies. They might be the more typical ones you see are workshop and coaching strategies. And then what are the mechanisms you're hitting? Leadership might be trying to improve leadership skills to promote sustainability, but the training of the staff might be competency in motivational interviewing. And then your implementation outcomes, as I mentioned, would be fidelity, quality, quantity. Let's say you're really good at it, but you never get a chance to deliver the intervention because of other kinds of barriers. So those are all things that would go into the outcomes. Service outcomes we put in here because they're not quite clinical outcomes like viral load, and they're not quite implementation outcomes like competency, but they might be like the number of people who received motivational interviewing, or the number of people who received PrEP, if PrEP is HIV prevention medication, or the number of people that got tested. Those are what we call service outcomes. So this logic model is a way of pulling in all the different frameworks I'm about to tell you about, because there are different frameworks for many of these different elements. All right, so we'll jump in. I'm going to give you a couple of examples. So The first example that I'm going to tell you about is a determinant framework. And what is determinant framework? Again, the barriers and facilitators that can make implementation successful or not successful. So this framework from Greg Ahrens, and there's a beautiful website that has all kinds of examples and tools. It's called EPIS. It's the exploration, preparation, implementation, and sustainment. There's two things going on here. One is there's different phases of implementation, which I'm going to talk to you about later when I talk about process. And then what's in the middle here are the actual determinants. So what? So what you can see is that you have outer context factors like leadership in the outer context setting. So let me start with inner. Leadership in the inner context setting would be I am working with a FSU primary health clinic, and the leadership of that clinic would be the inner context factors. Organizational characteristics, well, they're a publicly funded, academic affiliated clinical space that has never done research before, and they have strong connections with their community. Those are all things that could be barriers and facilitators. Quality and fidelity monitoring and support is there anything in place for quality assurance and fidelity monitoring of the intervention you're considering, or of any interventions for that matter? What are the organizational staffing processes? Are they understaffed? Do they have high turnover? What are the individual characteristics of the providers? Are they motivated to do new things? Do they have a community quality improvement focus or not? How do they handle feedback? Is there a defensiveness across the clinic about how they're doing? Maybe they've been audited and they've been, really concerned about quality improvement efforts, or they really feel like, quality improvement is critical for patient care. How do they feel about research? All those are inner context factors. Outer context factors would be the outer context leadership. So FSU Primary Health is part of broader Florida Medical Practice Plan, and so the leadership of Florida Medical Practice Plan, and even the Board of Governors at some level are leadership in an outer context way, right? Because they are leadership that dictate all state institutions in Florida. Service and environmental policies, funding and contracting, interorganizational environment and networks. So even across FMPP, are there networks that people can do similar things around quality improvement and implementation? And what are the patient and client characteristics? So patient characteristics are considered outer context because patients are not part of the organization. So that, and remember, in implementation science, you're not targeting patients per se. I'll show you some exceptions to that in digital health. But so your patient characteristics are really outer context because they're outer to the organization in the EPIS model, EPIS framework. And then what kind of advocacy is available for patients and clients. So those are potential outer context factors. Bridging factors are relationships between all these things. So there are things like community academic partnerships. Are there purveyors or intermediaries or facilitators of these different evidence-based practices that don't live in the inner or outer context setting? And then there's innovation factors. So that's the thing. So if I take motivational interviewing, is it a fit for the system, for the organization, the provider, the client? The developers of the intervention have characteristics like, are they willing to be adaptable in what gets rolled out or what's not, or are they pretty specific on like, you have to do it this way with this many sessions? And then the characteristics of the intervention itself in terms of things like how many sessions is it, how flexible is it, how adaptable is it in person, is it virtual, is it asynchronous? Those are all things that will affect implementation. So these are all the potential categories for EPIS specifically, and EPIS was developed with child mental health in mind, that could promote or interfere with successful implementation. Although, again, EPIS has been adapted now to HIV context by Dr. Badwani and myself. Another very popular framework is the Consolidated Framework for Implementation Research. It was developed a little bit more in biomedical settings. Then EPIS was a little bit more in mental health settings, although again, now with the growth of implementation science, there's definitely folks in both domains using CFR. And there's quite a bit of similarity where you can see there's innovation, which is the thing. There's the individuals, but individuals here cross the different settings that we talked about because they could be patients, providers, leadership. So it's a little different from EPIS that way, where they put individuals of all, like anything that's an individual human response goes into individuals. But there's still factors that are inner organizational and outer organizational. And then just like the EPIS phases are there for process on the outside, they also have implementation process on the outside. So to look more specifically at CFR, here's examples of the innovation itself, the source, if it's evidence-based, the relative advantage of this thing versus other things, adaptability, trialability, what's the extent of the evidence, complexity, design, and cost. Individuals, you could see here, high-level leaders, mid-level leaders, opinion leaders, facilitators, leads, innovation deliverers, and innovation recipients. So as I mentioned, all of the individuals that in EPIS are separated into the sections would be in this space. So some people prefer that and would pick CFR, and some people don't prefer that and might pick EPIS. And then the outer setting, critical incidents, local attitudes, local conditions, policies, laws, partnerships, connections. Here you can see bridging factors from EPIS are thrown into, are combined with outer setting, financing, external pressures. Inner setting, very similar, but a little bit different labels, structural characteristics, relational connections, communications, culture, tension, compatibility, all these things. And I should mention that CFR and EPIS, as I mentioned, have a lot of resources. CFR even has interview guides and definitions for all of these. So a lot of tools out there for you to leverage. In the EPIS model, processes were kind of basic: exploration, preparation, implementation, sustainment, and a little bit broad, but that it's really more timing, like pre-implementation is your exploration and preparation, and then implementation and then sustainment. Whereas in CFR, they have more specific determinants of the implementation process: teaming, assessing needs, assessing context, planning, tailoring strategies, engaging, doing, reflecting, and evaluating, adapting. These do overlap a little bit with the implementation strategy frameworks that I'm going to talk about next. But these are two examples of determinant frameworks. Determinants, again, all the way on the left side of your logic model, the barriers and facilitators of successful or not successful implementation. All right, we're going to move on to strategies. So strategies, again, are the things that your study is doing to promote the uptake of this evidence-based practice. And there is a taxonomy of implementation strategies called ERIC, Expert Recommendations for Implementing Change. As far as I know, Hannah, you might know if there's new ones, this is one of the only strategies frameworks. And one of the concerns I have, though, is that people, what they do is they look at this list of strategies and they pick which ones they think are most effective, but they don't have necessarily a methodological process for picking those. Ideally, you would have done some work to address all your to identify your determinants. And then online, there actually are one or two in the Northwestern group matching tools. If your determinant is this, here's the strategy you should consider. If your determinant is this, here's the strategy you should consider. But the evidence base for this could be stronger. And I also think the theoretical underpinnings of these strategies could be stronger. So what I mean by that is there's a strong, literature on, for example, organizational change in organizational psychology and business. So from a team science standpoint, we should be thinking about what are the theories: basic, behavioral, social science, organizational psychology, engineering, product flow, anything like that. I use system science. That could help you consider which strategies to choose. So this is some early phase work that you can consider. And again, Dr. Budwani and I are hoping to do more writing in this space. I wanted to give you one more example of something that is not billed as a strategy, implementation strategy framework, but is utilized that way. And I think we could learn from it and maybe can start to develop it as a strategy framework. So University of Florida has done a lot of work in this space, but across the country, PCORI has funded learning health systems, which we now talk about as learning health communities. I just want to take a second and tell you a little bit about this approach as a strategy framework. The idea about this is that you choose strategies from the data and the community of your institution, and then you have this continual cycle of rapid cycle evaluations of strategies through a quality improvement framework. And there's ways to do this rigorously because implementation science does differ from quality improvement in the sense that you choose strategies and you test them in very specific trial designs. But let's just say I'm thinking about I want substance use screening and referral across all the primary care settings and at what's going to be FSU Health. And so that's the evidence-based practice that the community prioritized, and substance use screening and referral is mandated, by many health systems and insurance companies. And so what do we do to get that going in a clinic setting? Well, in order to really evaluate it continually through a learning health systems or communities framework, you need to have some institutionalized continuous data to action cycles that integrate evidence into routine clinical practice. So, is there any EHR infrastructure or like a dashboard that tells clinics how well they're doing in substance use screening and referral across their primary care setting? That would be an implementation strategy that you could test within a learning health community framework. So something that allows a continuous data to action cycle, integrates research and practice. So the community is supposed to be research clinicians and community members together to work together for evidence generation and use. There needs to be organizational infrastructure support. So these are more implementation strategies, governance, leadership, incentives that support implementation as a sustainable practice. Collaborative co-production of solutions, another implementation strategy that you can quantify, measure, test. So I wanted to give you that idea because learning health systems are often combined with implementation science, and I think they are an example of implementation science, but not implementation science itself. It's a framework of strategies. So basically, you get data around your innovation. What does the data tell us? What do you have learned? What have you learned from it? You refine ideas, methods, and processes. You plan what you're going to do to increase implementation, and then you do it, and then you evaluate that, and you study it again, and it's supposed to be this continuous cycle. So that's the learning health communities approach. I want to make a few comments about strategies before we jump in. One is that there is a literature on adaptations and intervention adaptation as a strategy in and of itself. There's I didn't call this a framework for strategies, but it is in terms of adaptation. So frame looks at very carefully intervention adaptations. It documents those adaptations in terms of service setting, service setting, target audience, mode of delivery, cultural adaptations, what are the core components? And that's just something that at the minimum you need to be documenting, because if your implementation strategy includes adaptations and you're testing that, like maybe I'm going to test an adapted model versus a not adapted approach, then you'd be testing an adaptations and implementation strategy. But if adaptation happens during, let's say, like for my project, one of the strategies was that there'd be local implementation teams that would consider how to adapt the evidence-based practice. So again, I would need to be doing very careful documentation of when, who, what, and why modifications occurred as part of implementation. So that's one thing to think about. The other thing about strategies to think about is that there's a lot of kind of a hot topic and a lot of interest in funding around de-implementation. And so that is a whole domain to think about. I'm trying to think. I think I saw a recent application around opiate, how opiate laws and confidentiality laws may decrease ability to manage opioid treatment or decrease people being honest about use. And so we want to de-implement that practice. Another example is the old Scared Straight programming where they took prisoners and had them talk to juveniles about their experience and how awful and don't do these things because it's such an awful life. And it actually backfired where the youth they talked to didn't get better but they got better themselves. So that was the whole thing that we had to de-implement this whole approach of scaring people and confronting them about their use and their criminal behaviors and um, it wasn't effective. So de-implementation, a big deal. Some of the things that happen with de-implementation, identifying and prioritizing areas of low value care based on clinical evidence, magnitude of the problem or the harm, and the appropriateness. Facilitate the process of de-implementation by understanding the barriers and facilitators. And again, your determinants frameworks can be helpful here and deciding what strategies of de-implementation are necessary. And then here you move more into outcomes and sustainment of de-implementation, which we'll be getting to next. Okay, so that's strategies. So we've done determinants and we've done strategies. I want to now talk about process. So implementation process, I mentioned exploration, preparation, implementation, sustainment. So there is some specifics that these frameworks talk about when you talk about a process model. So for EPIS, you can just focus on your determinants, but you can also use EPIS as a process model. So your strategies fall under these different phases. So here you're evaluating needs and fit. There's an adoption decision, then you plan and you outreach regarding the evidence-based practice. These are more strategies here. Training and coaching begins. That's another strategy. Leadership and support for the evidence-based practice. Another strategy could happen here. And then strategies to make sure that it's being delivered in fidelity, and then ongoing quality assurance. So here you can see that your strategies can map on to these different phases, and you can have different strategies by phase or the same strategy that's done with a different purpose in each phase. As I mentioned before, CFR also has a process model that's not phase specific, but more activities. Planning does sort of fall in the active preparation and design for implementation. So that is sort of pre-implementation, engaging, also sort of pre-implementation, executing, and then reflecting and evaluating. So these processes are really map on to pre-implementation, implementation, and then afterwards they don't necessarily get into sustainment as well, I think. I think they're okay for a process model if you're not going to be doing strategies by different phases. But if you're really going to map strategies onto phases, I personally prefer EPIS for that. Okay, now your outcomes framework. So this is important because everyone knows REAIM and everyone's like, REAIM is my implementation framework. And REAIM is actually an outcomes framework. They do have an associated framework for determinants that they now have latched onto, kind of realizing that REAIM is really good for outcomes, but not for determinants. So on their website, you can see more about their determinants framework, but the original REAIM is an outcomes framework where it talks about different ways, different potential outcomes. Reach as an outcome, how do I reach the target, the intervention targets? They put effectiveness in here as an outcome, but as I've mentioned before, those are more for hybrid trials. If it's pure implementation, you may not be doing effectiveness of your thing. Adoption, how do I develop organizational support to deliver my intervention? And maintenance, how do I incorporate the intervention so it's delivered over the long term? So fidelity usually falls in the implementation outcome. The REAIM is nice for this because they do have checklists and they have more detailed outcomes and measurement approaches within each domain of outcomes. So highly recommend spending some time just weaving through the website. Proctor has a strong implementation outcomes framework. They categorize implementation outcomes in terms of acceptability, perception that an intervention is agreeable. Now, acceptability by whom? Usually we're doing acceptability by patients and clients much earlier in the research translational process. So I tend to think about this more as the organization or the provider acceptability if you're talking about implementation within an organization. Same with feasibility, the extent to which the innovation or intervention can be successfully used. Penetration is like, well, adoption is the initial decision, and then penetration is like really a fuller integration to use or try the intervention. Fidelity is whether it was delivered as intended. Appropriateness, how people perceive the fit or the relevance, the costs, and then the sustainability, how it's maintained over time. So these are all examples of outcomes that you could look for in evaluating and testing your implementation strategies. So, what are some of the challenges and opportunities in using models and frameworks? Well, little evidence exists on selecting, combining, and sequencing. There's a million frameworks. I showed you the examples of the ones that we most highly use, but we really don't know a lot about what's the best one for what. Multiple frameworks can be challenging in a grant submission, which is why I was mentioning the logic model. So you might really get into the weeds more deeply with one framework based on whether you're focusing more on strategies or determinants. But show a logic model that shows the frameworks that have influenced your logic model. And I tend to do that. Researchers use frameworks to structure inquiry, but practitioners use them to guide real-world implementation decisions. So that's just something to think about in terms of choosing a framework that really matches your context. And then, as I mentioned, matching tools are increasingly available where you can match determinants to strategies and then to outcomes. I wanted to take a few minutes to talk about digital health innovations. Most of the implementation models and frameworks were developed with the idea of implementing within organizations, but often with digital health innovations, we may be implementing centrally to a whole country or county or individual. So if the app you're using, let's say, as an example, or the device is done in conjunction of a physician's office, then that does make more sense with our more organizational based strategies. But if you're doing something that's more decentralized, where you have a company or your own department that is rolling out, an evidence-based practice across a larger geographical region, then that's what we call decentralized, and some of these things need to be adapted. So there's been two primary places where these frameworks were adapted. So for CFIR, source of the innovation versus source of the app, and this has been published, evidence and strength and quality, evidence base of the app. I mean, so there's a lot of basics that you can imagine, but some things to think about that I think are really critical is how adaptable is it to legal text, technical and contextual needs? What's the feasibility of piloting the app? What's the complexity for app rollout in terms of technology, onboarding, needing to maintain improvements, and what is the usability and design standards is something that you don't necessarily think about for more clinic-based innovations, and also what's the cost, and not just the initial cost of development, but the ongoing implementation and sustainment costs. ERIC has been adapted for digital health. That's been published as well. Some ideas are like assessing digital access, privacy concerns, device capacity, workflow fit, creating digital innovations for data security, onboarding, expectations. So these are all things that are really specific to digital. In this case, this was digital mental health innovations, but digital innovations. Using trained champions to guide onboarding and support adoption are some strategies. Training practitioners on the digital feature. Again, this was originally adapted for mental health, but I think is appropriate for other domains. Integrating data streams into EHR, automating monitoring workflows, supporting practitioners for managing remote or asynchronous interactions, So if you're going to be doing decentralized virtual counseling, for example, how do you train your practitioners to do this well? Let's see what else I have. Evaluate your acceptability has to be evaluated for user experience and content appearance more than the other kinds of acceptability that we talked about before. Adoption, as I mentioned, is whether an organization even starts to take on an evidence-based practice. And if you are having a decentralized trial, meaning that you're delivering this intervention from your business, from your department, from your office, as a researcher, then you're really still looking at consumer level adoption. I'm using a social media campaign to recruit. I'm delivering centrally. I'm not working with an organization or a clinic. And so this is often measured with paradata. This stands for behavioral intervention technology, which is how this was adapted, but it could be used for other interventions. Usability and workflow fit, usability testing and data stream analysis for feasibility. Fidelity is still important, even if you think you're automating to sufficiently that fidelity is all human error. That's not necessarily true because things like dose adherence and still the quality, let's say it's a chatbot, those are all still important components of fidelity. Implementation cost includes many different things like versioning, not something you would think about necessarily in implementation costs of other kinds of interventions. How well you penetrated the community. So if I'm trying to say I'm targeting all youth with HIV in Florida, here's the total number of youth, here's how many I actually got to do the innovation. And then sustainability is, again, funding over time, integration with health information technology systems, versioning updates, and long-term use. Things become outdated very quickly in this very rapid technology world. So I've now gone over to definitions. I've gone over different frameworks based on whether you're looking at determinants, strategies, or outcomes, as well as process. And I've shown you a couple of adaptations for digital health. So I just want to end with a couple of case examples from my work. So Naar 2019, we published a protocol that was called Tailored Motivational Interviewing Adolescent HIV Clinics. This is the study that I had mentioned earlier. And the aims are to determine the effect of TMI on provider fidelity. So that's our outcome. And TMI is the implementation package. MI is the innovation. We looked at two dimensions of fidelity, which is how well they adhered to the motivational interviewing implementation and how competent they were in the implementation. So did they attend their trainings? Did they complete their coaching? Did they do their role plays? And then secondarily, because this was a hybrid trial, which I'll talk about later, are the effectiveness outcomes, but those are not the implementation outcomes. These provider fidelity was the primary implementation outcome. And then we had a secondary aim that tried to look at sustainability, which is we gave them COPs, stand for community of practice. We gave them community of practice manuals on how you can continue to train and practice motivational interviewing. And then half the groups, we had funding to train a supervisor to hopefully continue the training and the supervision and coaching of the providers. We had an exploratory aim that was to look at the barriers and facilitators to implementation from the determinants framework. And because this is later phase, we're not looking at these to build our strategies. We were looking at these at the end to improve our strategies. And then to look at cost effectiveness. So those are the aims. So just to tell you, we use primarily EPIS. So we used EPIS in two ways. We used EPIS to identify barriers and facilitators pre-implementation. And we also used post-implementation and sustainment to guide program improvement. So we had qualitative interviews at the beginning and at the end. We also used EPIS as a process model. So we had strategies by phase. In the exploration phase, which was actually prior to the trial, so I was able to write this into the grant as something we did in preliminary studies to engage stakeholders and have them choose the evidence-based practice. This is across the Adolescent Trials Network, and they all chose the motivational interviewing. Preparation is these local implementation teams adapted the strategies. So they were given feedback on their baseline interviews. Here is what you said. Here is the barriers and facilitators. Now let's look at these different strategies and figure out how to adapt them. Here are the things we can adapt. We've got to get in 12 hours of this. We've got to get in this. We've got to get in that. But here are the things that you can adapt based on your determinant profile. The implementation strategy was primary training, audit, and feedback, but we did include ongoing implementation team meetings to promote leadership support. And then sustainment was what I mentioned, the training the supervisors, but also finding out ways that infrastructure might have changed to promote sustainment. So for example, a clinic says, every time we have a team meeting, we ask people, how did you use MI with this case? That would be an example of a change in infrastructure to promote sustainability. The outcomes were fidelity, as I mentioned, adherence to the program requirements and the MI competence. And then we also looked at penetration, like how well the clinic adopted and integrated the intervention through our qualitative interviews, and cost. A second case example is the Young Adult Centered Health Force training in HIV counseling, testing, and referral. That protocol has been published. The aims were to test the effect of the yacht implementation package, because sometimes you can test individual strategies, and sometimes, which I'll show you in the next design, and sometimes you're going to test a whole package to improve fidelity to the diagnose and prevent evidence-based practices. And the way that was assessed was mystery shopper assessments. So we sent young men who have sex with men to different testing sites across Florida, and they rated them on a standardized instrument on whether or not these different evidence-based practices were done at the visit. And then there was also a service outcome of the number of HIV tests among young MSM. The secondary aim was to assess the effect of continued quality monitoring. So after we randomized to the package included like feedback of your mystery shopper assessments, and then a facilitator would work with you to problem solve and figure out how to improve your scores for your organization. And so then we wondered, after we're done with that facilitation, if we just do ongoing quality monitoring and give them feedback, does that help sustain the primary outcomes versus just stopping? With the idea that if that's sustaining, then we can talk to the public health partners around, including this quality monitoring approach as part of the health department ongoing evaluations. Secondary aim was to utilize mixed methods at the end. So EPIS at the end to understand barriers and facilitators of successful implementation sustainment, with the goal of improving the strategies. And then, oops, that's a double. Oh, wait, no. Okay. So what are the frameworks that we used? We used EPIS because we were leveraging our previous work on determinants. So we didn't redo EPIS at the beginning, because we already had worked with HIV clinics so much. We had some good ideas of the determinants in our previous preliminary studies. But we did use EPIS, as I mentioned, to identify barriers and facilitators after implementation and sustainment to guide program improvement. This study's not done yet, so there'll be a lot of outer context factors, I can tell you right now. EPIS was also used as a process model to guide strategies by phase. So the yacht implementation package included an exploration phase where we engaged stakeholders with outreach, leveraging Florida Department of Health and previous collaborations. In the preparation phase, we did a contextual adaptation of strategies based on some of the interviews that we had done in previous studies. As I mentioned, we did not do baseline interviews in this study, but previous studies, and the mystery shopper assessments. They also got a site incentive and were able to think about how they might use that to improve their mystery shopper assessments. In implementation, we provided training and tailored motivational interviewing as one of the evidence-based approaches to improve culturally and developmentally sensitive counseling and testing. And we had evaluative and iterative strategies, which you can see described in the strategies framework. And in sustainment, it was, like I mentioned, looking at whether ongoing evaluation and feedback helped with sustaining any improvements in quality of HIV testing. Our outcomes for implementation were fidelity to evidence-based practice competency. So the mystery shopper assessments looked at things like risk reduction, quality of risk reduction counseling, whether they were referred to PrEP, whether they were competent in addressing cultural and developmental needs of the testers, and then also penetration, just in terms of how much did they test at all. So, some of the things that were happening were like a lot of the sites aren't doing anonymous testing, and so they are losing. They're not, people who are asked for ID are leaving. And now there's concern, especially about showing ID if you're not American born for HIV testing. So those are all things we're looking at in terms of penetration. Are they testing all the possible MSM who would be coming their way? All right, the last example, how am I doing on time? Okay, perfect. Is an example of a grant. So those first two are the first one was finished and published. The second one is actually we had to restart due to a shutdown, due to inadvertently misidentified shutdown of the grant, and now is restarted. And this one is one that's under review. So this is an example of digital health, where we were taking Healthy Choices, which is an evidence-based intervention that's designed to improve adherence and substance use in youth with HIV. And we've done several trials. We've shown efficacy, we've shown effectiveness, but we still are not getting youth to come to all the sessions. The clinics haven't taken it on as a regular evidence-based practice that they do. They are to a degree through the tailored motivational interviewing, but not in the 4-session intervention as it was intended. And we don't know whether they're using the MI to address substance use directly in the previous studies. So we wanted to take Healthy Choices, which has normally been delivered clinic-based, and add it to an existing digital health innovation called Health Empowerment, which is an app an app, kind of an app digital youth community that was developed by Institute for Digital Health Innovations, that includes, chat rooms and educational content and Ask the Doctor. And so it's really like a digital youth community. And then we were going to layer the Healthy Choices and deliver it from the app, where they could get a link to a virtual synchronous 4-session intervention with a counselor. In this grant, we are testing 3 implementation strategies alone and in combination. And we're using a MOST design, which I'll talk about in the next workshop. But the primary outcome is penetration. So how many sessions did the youth complete? Because this is a decentralized trial. So penetration is at the level of the consumer. Is the consumer completing the sessions? The secondary aim is to test the effect of the 3 strategies, which I'll describe in a minute, on whether the penetration of HMP as a component. So that's based on the paradata. Are they engaging with the app? How often they're engaging? What different components of the app are they engaging with? And then we have secondary effectiveness outcomes, because it's a hybrid trial, which I'll talk about later. We also are looking at what are the factors associated with the initial adoption. So who were we able to actually get to log on and onboard with them across those that were eligible? And then also to explore barriers and facilitators of sustainment with mixed methods at the end of the trial. So we are using a few different approaches. We're using CFIR, adapted for digital health, and that's going to guide our mixed methods post-implementation to guide sustainability and program improvement. The strategies we did not use a specific framework. What we did instead was focus on the theoretical approach, but you could potentially map them on. It's just that we don't have a lot of strategies for mHealth, implementation strategies for mHealth yet. So we focused on this adoption and penetration of the consumer. And so strategy 1 was a low-touch video introduction to the counselor, emphasizing empathy and autonomy and saying, I hope to see you next time. Strategy 2 is medium touch, tailored text messaging about, why the youth may or may not want to engage in these sessions based on their baseline questionnaires, if they miss sessions, having some tailored text messaging around missing and around their filling out, engaging with different components of the app. And then high touch is asynchronous individual support where the counselor can have one-on-one chats with the individuals to try to promote engagement in their healthy choices sessions or address in between session barriers to implementation. And then, as I mentioned, we use the Proctor as adapted for digital health for in terms of how we defined patient or consumer level. Really, we should say consumer level because these are not in clinics, penetration and adoption. So that is my big overview of implementation frameworks. Any questions or comments?
I hate to be the one to ask, but could we have the slides? Because I feel like there's a lot of extra reading that
Yeah.
it's going to take. I get the premise of all of this, and
Yeah.
all of it seems really straightforward, except there's a lot of detail.
Of course, yeah. So, Hannah, I'm not sure how you are going to do this, whether you want to distribute them just to the participants or whether you want to include any PDFs or recordings on the DISC website. I'm inclined to have the recordings accessible, but maybe just mail the PDFs to those who attended. That's my
Yes,
gut.
Sylvie, yeah. No, this was a phenomenal
Mm.
presentation, and I thank you for sharing the slides with us earlier. I was truly impressed with Mike, to your point, that the depth and breadth of
Yeah.
information in this presentation. I think, to your point, the right thing and the most accessible thing would be to have the recording online. And I believe Andrea has recorded this, which is great. And then the PDF slides will be sent to the attendees.
Yeah, yeah, because I mean, I wanted to give enough detail in the slides to understand that these frameworks are not just la-di-da.
Right.
But also the idea wasn't that you would get it all from that you would just leave knowing that
Yeah.
there are multiple frameworks to choose from. There's multiple things to think about when designing an implementation study. It's not a tack on, add on kind of thing to do it rigorously and in a fundable way. So,
Well, yeah, and also implementation science is a high priority for the NIH currently. So if you are in that space where you're applying for grants, if you can thoughtfully design your study as an implementation science trial, and it is appropriate to do so, it does bolster the rigor of the grants.
yeah, yeah, for sure. Okie doke. Well, thanks everybody. Thanks for coming, and we'll talk soon.
Thank you.
Yeah, thank you.
Thank you.